You might not know this, but we discover more than 200 outbreaks every year that could spark another pandemic. To stop the next outbreak from becoming the COVID-19 of tomorrow, we need to move quickly today. I'm Dr. Rick Bright, and I'm going to tell you how we can prevent the next pandemic. Three things hold the key to an early pandemic response: collection and sharing of data, a trusted early warning system, and modern data analytics to pull it all together. As part of our work to create a Pandemic Prevention Institute, the Rockefeller Foundation is already building the partnerships and tools necessary to meet this ambitious goal. We're committed to making these measures transparent and equitable, and we believe they will keep the next outbreak localized and controlled wherever it happens in the world. It's important to start now to avoid the damage of another COVID-19. It's the only way we can stop the next deadly disease. That's how, together, we can stop pandemics for good.
Hello, and welcome everybody to our discussion on pandemic prevention and identifying, spotting, tracking, and responding to COVID variants. I am very happy to be moderating this conversation with these esteemed colleagues, Dr. Jitu Mayer calling in from India, Dr. Sam Scarpino, the Managing Director at the Pandemic Prevention Institute, and Dr. Bertha Hidalgo, calling in from the University of Birmingham in Alabama. Before we get started, I'd love to welcome everybody who's calling in from various locations. Please let us know where you're calling in from and let us know your questions in the chat. Time permitting, we will address those questions towards the end of our discussion, and we'd love to hear from you throughout the discussion on your remarks, observations, and thoughts as we talk about this very important topic. I'll go ahead and give some brief introductions to my esteemed colleagues, as I mentioned. Dr. Jitu Mayer is a cell biologist and director of the National Center for Biological Sciences in Bangalore, India. He's also the chairperson of the Bangalore Life Science Cluster, a multi-institutional organization that is working on fundamental research in the area of cell biology. He has also pioneered many opportunities for education and community building in the life sciences in the country. Mayer has been involved in steering COVID-related activities at the Bangalore Life Science Cluster from the very start of the pandemic, working with public health officials in the Karnataka state and the city of Bangalore. Dr. Sam Scarpino, Managing Director of the Pathogen Surveillance at Rockefeller Foundation and a member of the Pandemic Prevention Institute. He's also an affiliate assistant professor in the Department of Physics and holds appointments in the Network Science Institute, Khoury College of Computer Sciences, Global Resilience Institute, and Rue Institute of Northeastern University. In this capacity, he directs the Emergent Epidemics Lab and is the co-founder of Global.Health. Scarpino has 10 plus years of experience translating research into decision support and data science, machine learning tools across diverse sectors from public health to clinical medicine to real estate and energy. And finally, Dr. Bertha Hidalgo is an associate professor at the Department of Epidemiology at the University of Alabama in Birmingham in the School of Public Health. She holds degrees from Stanford University, the University of Southern California, and the University of Alabama at Birmingham. Her research specifically focuses on health disparities related to COVID-19, cardiometabolic diseases, with a special focus on Latino populations and genomics. So a really wonderful group to be talking about this important topic. I'm sure we'll have lots to say. I'll go ahead and kick it off with a big picture question. And we'll start with you, Dr. Mayer, about your experience in identifying Omicron in India and the current genomic surveillance systems and insights that you might have in your experience there.
Thanks, Jessica. Well, first for that introduction and also for this opportunity to be part of this panel. I know I should add that our experience in identifying the first Omicron variant in India wasn't sort of entirely out of the blue. It had a bit of history, and that's connected to the the genomic surveillance structures that we set up in the country some time ago. In early, or I think mid-December last year, the Indian government decided that it needed a genomics consortium to build both capability as well as rapid response to the emerging sort of variants in the SARS-CoV-2, especially after the first uh, wave of epidemic in the country. Um, so the Indian government set up what is called INSACOG, which is the Indian SARS-CoV-2 uh, network, a network of about 28 government laboratories across the country, looking at and sequencing variants sequencing viruses as they emerged amongst the population at some rate. But at the same time, while this was happening, uh, some of us felt that there would be a need to do some sort of high density sequencing as well in some of the populous cities of the country. So, with in fact the Rockefeller Foundation, the we proposed that we should set up as I mentioned, a high density sequencing activity located in Delhi, in Pune, in Hyderabad, and Bangalore, where we had a set of 4 different institutions across these 4 different cities, working with the local city officials to build sequencing networks, both with local public health officials, sending us samples on a regular basis, and also trying to leverage the sequencing capacity that we had in our cities. So, given all these, given this structure, both the government network as well as this parallel, which was a surveillance network, and the parallel sort of high density network, we just so happened to be I should say, in the right place and the right time, but obviously for the wrong reasons, because we were not looking for finding a new variant, not finding the variant in India, but. What happened was from some travelers and from a hospital, sequences emerged. The virus samples emerged and were given to one of our partner sequencing labs. In fact, a private lab called Strand uh, Strand Life Sciences, and they, in fact, sequenced the variant almost within days of receiving the sample, and contacted us because they were connected to our network as collaborators, and indicated that we should alert the officials. And so all this happened within a matter of literally 4 days from the time the samples were sent to them, and we got in touch with the national network, mentioned this to them, and immediately alerted the local city public health officials to start their contact tracing and bring in sort of immediate measures. So I think, in some sense, this was preparedness of some kind that brought about this sort of a rapid response, and this happened to be about 2 weeks after the announcement in South Africa, and
Wow.
for that period, the Indian Indian networks had not picked anything up, but as I said, we just happened to be prepared and vigilant, and the variant got picked up. So, and I think there were some lessons to be learned, which perhaps I can talk about them later or now if you wish. But because I've gone on a bit, so I'll stop here and see what you have to say. Yeah, I mean there
Thank you,
are some
G2.
lessons to be learned from this whole thing. Yeah, but I think I'll stop here now. Yeah.
Thank you, G2. I think you brought up a number of really interesting points, including the fact that it's not just the existing and emerging genomic surveillance techniques that we have that can provide this data, but we need collaboration across different sectors to make this type of work really meaningful globally. I know that you are partnered with the Rockefeller Foundation. And Sam, I'd love to hear from you about some of the new technologies and techniques that are in the horizon that we are working on with our partners that can improve this type of rapid genomic surveillance and data sharing.
Thanks so much, Jessica. It's a pleasure to be here and an honor to be speaking alongside my two distinguished co-panelists. What we're building at the Rockefeller Foundation's Pandemic Prevention Institute is a trusted network of collaborators that share access to information and pool our resources so that we can get out in front of infectious disease outbreaks. We want to be able to contain outbreaks at source before they become even epidemics, much less pandemics. And just like we need to take an integrated approach to public health, right? So we need masking, testing, ventilation improvements, along with equitable vaccination. We need to take an integrated approach to our data systems. So clinical genomics, critically important. We saw how important they are and how important data sharing is, from our partners in South Africa, Professor Tulio de Oliveira, Siri, University of Stellenbosch. We, of course, also saw the potential risks associated with punitive border closure. But we need to be able to layer in multiple different kinds of data on top of and intermixed with these clinical genomes. So what do we mean by this? Well, wastewater-based surveillance has been front page news over the past 48 hours as we see cases detected in places like Sacramento and Merced in California and places like Houston in Texas before clinical genomes are detected. We also know that wastewater-based epidemiology has been used effectively, for over 10 years as a part of the polio response. You see that polio virus shows up in the wastewater, and then we can deploy resources to contain that outbreak. And this is really critical for encouraging and supporting data sharing. Instead of punitive travel bans, we need to trigger the deployment of resources to help countries, help jurisdictions contain outbreaks, ensure that they're supported and have the tools that they need to provide that critical public health response. Now, in addition to molecular-based surveillance coming out of wastewater, coming out of clinical genomes, we need to bring in these digital trace data. So what are people talking about on Twitter, Facebook, Instagram with respect to their health status? What are people responding with in terms of their mobility? Are they able to shelter in place? Are they changing their patterns day by day? So we can look at data from telco, from smartphones. And now you might be all thinking to yourselves, well, what are the ethical and legal considerations? And that's another area that the Pandemic Prevention Institute is really active in embracing. How do we do this in a responsible, ethical way that respects data sovereignty, respects privacy, and upholds the highest ethical standards? So trying to bring all of these pieces together are really critically important. The last thing I'll mention, and happy to go into more detail about this, is working with groups like the Pandemic Tracking Collective that, Jessica, you are a critical part of, to understand how do we actually bring good data, better practices, best practices to this public health data space, and understanding what needs to be done both on the technology side, but also on the standards and reporting side to ensure that actionable, high quality information is available in real time.
Thanks, Sam. That's all very exciting. And I love your mention of the different types of surveillance, that it has to be multifaceted, it has to be comprehensive, because there are so many ways to be effective at identifying early warnings, indicators of what could be possible pandemic threats. Bertha, I'd love to hear from you, since you have a lot of experience in genomics and on the research side at a university. This morning, I saw that we have now identified Omicron in 21 states and counting. I haven't seen Alabama on the list yet, but it seems like it's probably a matter of time. I'm curious what you're familiar with in your public health system there, and even in your university, to prepare for the identification and reporting of Omicron cases.
Yeah, thank you, Jessica. And also a big thank you for having me on here today and inviting me to share this space with you all. I agree a lot with what Sam said with respect to needing to be more proactive in the actions they're taking. I think what has become really clear during the pandemic is that we have been extremely reactive, and oftentimes reactive too late. And unfortunately, we seem to be repeating a lot of the mistakes of the early times of the pandemic, even now with knowledge of Omicron. And as you noted, Alabama is not yet on that list of states where we have identified it. But in public health and infectious disease and other textbooks, I think we fail to recognize just the speed at which we now travel, the interconnectedness that we have with other people, and that we need to be more aware of the ways in which this virus can spread in such a rapid manner that just because we haven't had Alabama on the list yet does not mean that Omicron is not in the state of Alabama, right? It does not respect state borders. It doesn't respect country borders. And unfortunately, also, public health has been significantly underfunded for so many decades that part of the reason we probably haven't identified is because we simply don't have the capability at the state level to be able to rapidly identify it as quickly as potentially the private sector or other forms of identification. So I would love to be more in general as a country, within our states, part of a more collaborative effort that really embraces the diversity of the populations that exist in every state, that embraces the knowledge that each state and the resources have, so that we can have a better coordinated response against this, not only Omicron, but the pandemic and future pandemics as well.
Absolutely. I think that's a wonderful transition to talking about some lessons learned. Before I do that, I do want to remind our listeners and our watchers to let us know where you're calling in from, where you're dialing in from. Pop in your questions in the chat. We'd love to hear from you. If you're late to joining us, this is Preventing the Next Wave, Spotting, Tracking, and Responding to COVID Variants, where we are talking about all the things about detection and how we can prevent the next wave from happening again all over the world. So Dr. Mayer, I would love to hear from you. You mentioned that there's some lessons learned on the practices that you've already done with surveillance and these partnerships. Can you let us know some of the biggest takeaways from your experience so far?
I think the point that Sam also mentioned, the idea of having some kind of a system that provides a transparent and quick reporting of all the information that's being gathered on the ground, and that being shared equitably and quickly, both locally as well as nationally and internationally. I think that's, to me, a very important lesson, because had the South African team not announced this, the discovery of the variant at the time they did, when I think they were not that convinced that this was this was going to be a variant of concern. Nobody would have picked it up as fast as we have seen it literally being identified across the world in less than 2 weeks. In a sense, this variant has probably been circulating longer than that, but had it not been picked up and announced, it wouldn't have happened. The issue that I feel that the punitive actions against South Africa, but also the tendency for governments also to try and put a lid on such information is also somewhat concerning, and I think that's a that's an area which I think could deal with some amount of agreement across the board. I mean, both nationally as well as internationally, that that we need to come to some agreements that when we discover such potential threats, they are immediately transmitted, of course, responsibly, but the information is known and made known widely. So that's sort of one of the lessons I feel we learned, and I mean also we keep relearning for some reason. Um,
Mhm.
and another important aspect of the preparedness, I feel, is again building these rapid warning systems like the sewage surveillance or the environmental surveillance systems, and building a global network for that. Uh, and I mean, I don't know how how feasible that's going to be, but I certainly think that's going to be an important element of our of our preparedness for the future. And this is another thing that we have set up in both these different consortia, both the government one as well as the one that we are driving through these institutes, a sewage surveillance system. It's not up and running yet in full pelt, but I think it will be going soon. Yeah, I'll stop there. Thanks.
Yeah, that's you bring up some really wonderful points. And I think that we should spend a couple minutes talking about the value of data transparency, which is a really core value of the work at the Pandemic Prevention Institute and the Pandemic Tracking Collective, knowing that public health data belongs to the public. It is something that should be available without kind of limitations based on varying levels of accessibility. And to not have that creates more confusion and doubt and allows for misinformation and really bad takes and interpretations of this, not to mention the fact that it possibly fueled a lot of these punitive actions because of our inability to communicate the fact that identifying something doesn't define origin, right? So we have falsely blamed South Africa and punished South Africa and South African countries for this early warning that they sent out to the world. But really, we owe them a ton of gratitude for how incredibly robust their genomic surveillance capacities are, which outcompete, I think, the United States by far. Sam, I'd love to hear from you about some of the ways in which Pandemic Prevention Institute is working to make that data public, to share it with everybody and translate it so that it's not hidden on dashboards behind paywalls or really difficult to understand for the average person.
One of the things that our CEO, Dr. Rick Bright, says that I find very powerful is that the world has over 7 billion or close to 7 billion first responders when it comes to pandemic prevention. And this doesn't mean that we're passing the buck from the public health agencies and the governments onto the individual. What this means is people need to be armed with the data and information to keep themselves and their families safe. And what that means is that people need data that is relevant for their environment and contextualized for the decisions that they need to make. We've seen across every country, internationally, within cities, that the burden of COVID-19 varies dramatically, often reflects things like racism in the United States, organizational principles of xenophobia, other forms of hate internationally that drive differences in disease burden. The result on the data side is if I'm going to decide I should do today, what is safe and what is less safe, I need data on Washington, D.C., where I live. I need data on the neighborhood in Washington, D.C., where I live. And it's not something that even as a member of the Pandemic Prevention Institute, I can do on my own. I need to have a network of collaborators that trust each other, that will share data publicly, that will also share data into an ecosystem that allows access not just to the data, but to build the kinds of applications that help me understand the risk. The analogy that really sticks in my mind is if I'm going to take an umbrella out, how do I decide to do that? Well, I get out my smartphone and I look at an application on my smartphone. And that application has a weather prediction, not even a forecast, just a nowcast. And that weather prediction does not come directly from the National Weather Service in the US. That comes from an app that looks at the National Weather Service. The National Weather Service builds off of the data. So I don't go directly to the data, I go directly to the insight that tells me something about how I should act to keep myself protected from the weather. And that's what we want to build at the Pandemic Prevention Institute, and our building is this trusted network of collaborators, these integrated data systems that power tools that people about how to keep themselves, their families, their neighborhoods safe, while acknowledging that we need to keep economies open. We need to have social connections. These things matter for our, not just our financial health, but our mental health, our physical health, and our social well-being.
Absolutely. And Bertha, I keep thinking about you as a fellow science communicator that has braved the world of social media to try to translate all of this emerging data in accessible ways. And I think Sam brings up a good point of mentioning how risk is oftentimes not very clear when you just see very scary, ominous headlines or very, xenophobic, racist, isolating type of conclusions on countries and peoples. What are some effective ways that you have found to help define things like absolute risk and relative risk so that the average person who sees a headline of mutations causing a new variant are not, feeling like we're back at square one?
Well, thank you for all of those points that have been raised. I think among the lessons learned, probably the most salient has been that it was unforeseen for some people just how powerful the mis and disinformation epidemic was going to be, and really also a pandemic, because I think what we also saw was that even though many of us, like you, Jessica, who have been so central in combating that mis and disinformation, that what we see is that the challenges to the mis and disinformation that were happening in English language did not immediately translate to other non-English languages, and that there was far less combating of that information, and unfortunately did lead to greater disparities in incidence of not only disease, but hospitalization and death due to COVID-19. And that it's something that I think that as public health practitioners, we need to think more carefully about how we address the transfer of information, the transfer of knowledge, but also how and that knowledge transfer will lead to behavior change. Because I think the other thing that we're dealing with respect to science communication is literacy and truly understanding the messages that are being communicated and how people are interpreting them. And I think, when we talk about trust, there is a lot of mistrust in just big company, big everything, that people are unwilling to accept the information that is coming from those specific sources, and went to people like Jessica and other science communicators, some myself, that took individual conversations to move someone from vaccine hesitancy to fully vaccinated, everyone in their family vaccinated. And so it's really hard to have those conversations one-on-one on a daily basis, where it's the select individuals that are doing this on Instagram or Twitter or what have you, the other digital platforms. And so how do we capitalize on that trust factor, those trusted sources, so that we can move forward again in a collaborative, sort of, very unified way, and really make the mis and disinformation sources so minuscule that people are willing to consider it fray.
Absolutely. You bring up a good point too and this has come up a number of times in discussions throughout the pandemic, of how we really should be treating trust as a social determinant of health. And when we don't, we miss the opportunity to really care for the different populations that are experiencing this pandemic in very different ways. We're talking about extremely disproportionate burdens and health outcomes among the Latinx community, among Black and Brown people in the United States, and even globally. If we think about the fact that one of the consequences of the lack of vaccine equity is the emergence of variants. And so I'd love to shift to talk about equity and access and what that has looked like in your community, Bertha, in the Latinx community, even in India. G2, I'd love to know about accessibility and availability to those things, because we understand that under-vaccinated and unvaccinated populations create these vulnerabilities, not just for those populations, but for all of us.
Yes.
G2,
Well,
I'll let
maybe
you
I'll
start.
start then. Oh, sorry,
Yes,
go
please do.
ahead.
Please. Go ahead.
Go ahead, Bertha. Go ahead. Yeah.
Thank you. It has been really interesting to observe the rollout of vaccines because I am originally from California and very tied to what's happening in the state of California. I still live in the state, my extended family, and yet my personal experience has all been in the state of Alabama because I reside there with my family. To this day, the entire state of Alabama has less than 50% of its population fully vaccinated. I think in the 5 to 11-year-old category, we were at 2.1% last that I checked. That is in stark contrast to many of the other states like California, for example, which are not only more populous, but have a higher potentially risk because of that larger number of individuals that live in the state for higher risk of being infected with COVID-19, overflow very easily, etc. And we need to see increased vaccine hesitancy in the state that really leads to poor uptake. We see that even individuals who were willing to vaccinate themselves as adults are unwilling to vaccinate their kids. There's just a disconnect between what they think is safe for their bodies and not safe for their kids' bodies. And, it's really hard to communicate that this vaccine, it's a lower dose, are almost non-existent for the youngins, and that this is something that they should be encouraged about, and that we have seen spread in schools of COVID-19, and the shutdown of schools leads to parents at home because they can't go to work. It's a domino effect, and I think it's really perplexing to me to see the also disparity in the non-pharmaceutical interventions that are playing out in each state. So I have been walking around the state of California the last 2 days while I'm in town visiting family, and everyone's wearing a mask, and that's just not something that you see in our state. In the state of Alabama, it's rare to wear a mask, definitely not outdoors. All masks have been removed from indoor activities, and so it's again this lack of coordinated effort that I think that is leading to also confusion about what people need to or not need to be doing at any given time. Just because one state is surging and another isn't doesn't mean that we're not still all at risk. And so I think for me as an epidemiologist, as a public health practitioner, it's the most perplexing time to be living in. And I think that these last 20 plus months have probably been the most formative of my training as an epidemiologist, because it's just, you're relearning how epidemiology plays out in the context of human behavior that is heavily influenced by mis and disinformation and just general confusion about what needs to be done.
Kumar, thank you for that. G2?
Yeah. Yeah. I when you talk about equity and the and the availability of various public health and health resources in India, of course, I mean this is a very skewed society, and there is huge inequity, and I think, and that was starkly visible in the second wave, which hit India, so in such an extreme way. I mean, we had, it turns out after the second wave, almost 67% of the population were infected. I mean, this is 1.2 billion people, and of course, the number of COVID deaths that were counted were maybe a factor of 10 less than what actually occurred, and a lot of this was because of the really very poor preparedness of medical supplies, simple things like lack of oxygen in hospitals and across the country. So I mean, there has been very serious very serious I should say lack of health resources, and it could have been foreseen, but of course, nobody could foresee the huge impact of what one of these new highly spreadable variants, the Delta variant, could accomplish, and the speed at which it moved across the country as well. So so at some level, one could argue that the numbers that came about in the second wave would would be signals for preparing for what could happen now in the future. So and I just hope that we don't go by official figures to make preparations for what could in turn be a very serious third wave in this country. I mean, I know many other countries like Europe and all have had third and fourth and fifth waves, and but the health systems there are much stronger, and I think simple uh, access to basic medical supplies that we know are essential for preventing deaths, need to be heavily resourced and heavily sort of made available in the days to come. Now, so that's sort of one part of the story of how a system responds to something that has happened in the past, and whether it sort of chooses to ignore some of the messages that have come from what we've experienced, or not. Uh, I mean that. Having said that, I think on the other hand, the vaccinations in the country have been actually, taken, taken really center stage, and there have been fairly large numbers of people vaccinated. But perhaps 70% of the population within the 67% who've already been infected, 70% of the population have actually been given at least one dose, or maybe more by now. Maybe the number is around 80%. So I think which means that the second dose will happen in the next few months. I just I hope that happens soon. But with variants, as you know, of the kind that are now circulating, we are somewhat in the dark about what these vaccinations to the prepared for the older for the original strains. I mean, what the impacts of that will be. So I think there again, while the countries of the north in some sense talk about boosters, here there is, although I mean there is a availability of vaccines. Everybody is not vaccinated, and until everybody gets vaccinated, boosters are not even going to be discussed. So in fact, boosters are today completely out of bound for most people, unless I mean, we've been trying to say that maybe healthcare workers should get boosters, because healthcare workers have been vaccinated more than 6 months ago, and I think for them to be healthy is so important for the rest of the population. So those sorts of measures, I think, need to be thought through as we move along in this pandemic. That's. I'll again stop there and wait to hear what the others have to say. I think equity again is so so relative in some sense. It depends on where you're speaking from.
Yeah.
Right. Right. Thank you, G2, and thank you, Bertha, for those thoughts. Just addressing those who are in this room with us, we have viewers from all over the world. We've got many from the U.S., El Salvador, Sierra Leone, a number of U.S. states, including New York and D.C., and we've got our first question. So I'd love to pose that to you, Sam, actually, which is a great transition at thinking about what we just talked about. What do we need to do now to protect ourselves and to improve our availability to catch the next variant as early as possible?
Thanks so much for the excellent question. And I would actually say that probably the first thing we need to do is understand that we are all in this together, and equity is critically important for our ability to exit from this pandemic's acute phase into something that's more manageable, and also the next pandemic. One of the hallmarks of this pandemic is the hallmark of nearly all infectious diseases, which is that it tends to be wealthy individuals traveling that spread to new countries. And then it tends to be individuals who are marginalized and impoverished that bear the disproportionate burden in terms of morbidity and mortality. One thing that really sticks in my mind, Nathaniel Hawthorne, who wrote The Scarlet Letter, has a short story about smallpox in Boston that's brought in by wealthy individuals and then decimates the poor communities of the city. And so this is nothing new to public health. We understand how this happens. So we really need to come together around this critical piece of equity. On the data side, it's wastewater-based epidemiology that we need to be investing in, not because it's a panacea, but because this is the kind of passive, always-on surveillance system that has the molecular information we need to detect variants, to detect novel pathogens, to monitor persistent health threats, cholera, polio, antimicrobial-resistant infections. But of course, these data need to be layered into a system that actually responds, that helps people contextualize what's going on. If we're going to get out in front of this pandemic, we need to have these kinds of surveillance systems. I mean, the last thing I would mention is, of course, there are serious ethical considerations. We know that wastewater-based surveillance is used to track down individuals that are using narcotics and make arrests in different countries, violating people's privacy. And that means, and this is what we're doing at the Pandemic Prevention Institute, that we have to embrace these new emerging ethical challenges as we start to embrace these new and more powerful systems for surveillance. Surveillance can be used to empower communities. It can be used to disempower communities. And we need to engage with the broad stakeholders as possible to understand what the challenges and opportunities these data sets are.
Absolutely. Bertha, I'd love to hear your thoughts about the question.
Oh, Jessica, I have so many. I think that what I struggle with as I talk to people in the community, people who are non-English speaking, who are working 60 to 80 hours a week, who cannot take the time to recover after getting, their second dose, where maybe symptoms are more likely, or who haven't had a chance to listen to the news that evening, or scroll Twitter, because that's not even something is within their realm common day practice. That they're just so uninformed, and they're just, their main worry is putting food on the table, paying the rent, and making sure they show up to their 2 or 3 jobs every day, every week. And how are we going to protect those people so that we can all be protected, as Sam is so astutely pointing out? I don't know. We have done some education, boots on the ground, where we host focus groups and we talk to people in communities. And, I think what's also really come out of this is that it's not urgent information that has any relevance until it comes front and center in their lives, until someone is infected in their families, until they are actively seeking out that information, and then the information that is out there already makes sense. And so how do we bridge that gap between making sure, again, that the knowledge transfer is successful for all communities, for all individuals that need this information, and that the onus of protection isn't just on the individual, that we are putting in place systems that are going to protect people because they don't have the time to protect themselves. And so I don't know the answer to this. I think that we know that we are behind the 8 ball with respect to this pandemic. I know that we are being very reactive and not proactive in our actions with respect to stopping the spread, and that we are not working together to make sure that we are all reading the same page out of the same book that we know, will tell us the story and that we know the ending to. Moving forward, I think, some of the efforts that you're describing are really important, and I hope that we can make sure that they are successful in bringing this virus to a stop, quite frankly, that we are working towards making sure that that pandemic is not going to be something that really sort of, destroys our morale completely.
Yeah. G2, do you have any thoughts on this question?
Yeah, I had some sort of orthogonal kind of thinking about how can we think about preventing the next pandemic, right? I mean, and I'm going to say this here. I think putting in a lot of technology and putting in systems to track and systems to trace is very, very important. As long as as long as we've already accepted the fact that we're going to let these pandemics happen, right? And the reason we are letting these pandemics happen is because of this, the collapse of our ecosystems, a collapse of
Yes.
our natural habitats for most of the species on this planet.
Yes.
And it's also because we've really given up I mean because if you think that only by tracking and by staying one step ahead we're going to be ahead of the game. I think we're mistaken, because there will be a pandemic which will be so ferocious that none of our technology will work fast enough. So I think the root cause of some of these pandemics is sort of this incredible loss of our natural habitats for the species that harbor most of these infectious agents that are benign in wild animals, but completely devastating in perhaps the largest biomass uh, uh, accumulator or aggregator on this planet, the human being. So I think that to me is an important issue, which, coupled with our climate change discussions that have been going around, I mean, those two discussions need to come front and center if you're going to talk about how we're going to prevent the next pandemic.
Yeah.
Certainly true. The concept of One Health, which is the kind of the harmony that needs to exist between all these ecosystems, humans, plants, animals, was central to my education in graduate school when I studied emerging infectious diseases. We were always taught that it was a matter of when, not if, that an emerging novel virus would come out of the clashing of these ecosystems that is driven by a lot of human behavior, things like climate change and deforestation and overconsumption and travel. And so we've globalized disease, and that is certainly something that we should recognize. It's not something that should make us feel hopeless, because we do have tools to, if they're well funded, like Bertha mentioned, and have good systems in place to keep them running, we could have these early indicators and warnings to prevent them from becoming catastrophic. But their inevitability is something that we should also talk about. This brings me to another live question that I'd love to hear from each of you. I'd love to hear one question for each of these. So what are you most I'll start with pessimistic. What are you most pessimistic about and most optimistic about for our ability to prevent future pandemics? So one thing you're pessimistic about and one thing you're optimistic about. Sam, I'll start with you.
Well, I would say that the thing I'm most pessimistic about is what we just heard described. It's not going to be climate change that gets us. It's an infectious disease that emerges because of the effects of climate change and sweeps around the globe. It could also be antimicrobial resistant bacteria. In terms of the optimism side, one of the things that we're trying to address with respect to equity around wastewater-based epidemiology is how you can leverage this technology outside of the sewage treatment plants, outside of the United States, the UK, Western Europe. We needed to function in those countries, but we needed to function in rural areas and internationally. And so I think there is a scenario where our partners in Ghana detect an emerging infectious disease outbreak, at the human-animal interface, potentially via wastewater-based epidemiology, that triggers the release of resources and contains the outbreak before it starts to spread. So the optimistic side is the system is working. It's working in the background. It's always on. It's always running. It's always containing these outbreaks. And we can just move on with addressing the root causes that we heard about, like climate change, deforestation, all of the things that are driving this increase in infectious disease outbreaks.
Bertha, I'll let you go next.
I'm not quite pessimistic yet about this, but I am. I remain hopeful that what we have observed with respect to human behavior and the spread of mis and disinformation will be something that we will learn to sort of contain and temper. Because I think that remains sort of a major threat in our ability to share evidence-based information with the communities that most need it. I think I am most optimistic about the collaborative efforts like this and others that have happened. The science at the speed at which the science has provided not only a super effective vaccine, but also antivirals and monoclonal antibodies, and all within a span of less than 2 years. That is unforeseen, and I think would have been unforeseen any other time in the past decades, and that we really have the tools in place to be able to do something really quite spectacular in terms of control of future pandemics if we can get all of these other factors in place that will allow us to be successful. And so I hope that conversations like this will lead people to think more carefully about the ways in which we move forward. And I think that there are a lot of great ideas that lie out of the ivory towers and institutions that are actively working to identify how best to move forward, that we could really have a grassroots effect where we are leveraging the very creative ideas that exist in our communities that can help us better leverage this as we move forward.
Definitely. G2?
Yeah. Well, I think both Sam and Bertha have just, said almost everything that I could have said. I'll add just one, one point each, as you mentioned, on the optimistic and the pessimistic spectrum. I tend to be, somewhat skeptical about about how we will achieve equity across communities and across societies and across the globe. And I think it's very important that we think about emerging infections also as caused by disproportionate consumption patterns across the planet. When there's disproportionate emissions in one part of the world, the other part of the world bears the brunt, and there is, in some sense, a very complex kind of price that people pay across the world. And I think the pandemic is reflecting that we're paying the price of such inequities at some level. And I don't know. I'm a little pessimistic about how this will be resolved, but it must be. But I'm very optimistic about the younger generation of our colleagues, perhaps younger than all of us, who have just been incredibly active and motivated in taking many of these issues on head on, and saying the world is ours. World is, ours to live in. And you guys, all of us, well, me, not as much you, have brought it to where it is. And I think in some ways that's the optimism that I'm seeing, that they really have a grip. The younger generation in the world has, and these are young, let's say school children as well as young college-going kids. They really see the kind of world that they want to shape the kind of world they're living in and make sure that it doesn't run away from the possibilities that it offers. So I think that my optimism comes from my engaging with the younger people who who are really taking this on head on. So I'll stop there, and I can only salute them.
I love that. I, as a person who errs on the side of pessimism, hearing all of your optimism is encouraging to me, because it's very hard to be optimistic sometimes when you're stuck in the data and looking at the trends. But I share that optimism. I do think that there are some very encouraging trends that we've seen in public interest in public health, and even people's awareness of the fact that there is a good sense of altruism in a lot of the choices that we need to make to help end this pandemic and possibly prevent the next one. I'm going to finish with one last question because it's just too good to skip. Hopefully we can get it in the next 4 minutes and wrap this up. But the third question from our live audience is, what can be done to educate the people in a way that can start trusting the science and doctors and the fact that they don't understand? I might start myself just by saying, as a science communicator, this is something I think about in all of my efforts, in that we are responsible for helping increase science and data literacy. And we do that by thinking of, trust as a social determinant of health, and maintaining that trust and not letting it break is one of the most important values that we need to have as sharers of this truth, as sharers of this information, knowing full well that science evolves, that science is emerging, that we need to add caveats and disclaimers and warnings as we present things that are still in the process of review. But I think that by emphasizing what we talked about earlier, which is data transparency, so that things are not shrouded in darkness or made to believe that they can't be accessed by people who don't have our specific training, is one of those ways that can increase trust, by being very, very generous with the public, with all of this data, and sharing it for the purpose of informing and not causing fear and panic, which is very much the motivation from bad actors in this space. That's something that I feel like has been a huge priority for myself. Sam, what about you?
Well, first, I just want to thank you, Jessica, for such an excellent job moderating. It's been so much fun having this conversation. Also, my co-panelists, and of course, the Rockefeller Foundation for hosting. Science communication, science communication, science communication, right? That's the answer. On the Pandemic Prevention Institute side, what we are trying to do is acknowledge that if there's an information asymmetry, that provides an opportunity for people with an interest in influencing people through fake news to sully the truth. And we have to provide the data so that we can then derive insights and information and empower people with knowledge. We also need to realize that people want to learn and understand. And as you said, Jessica, if we go into it assuming that people don't want to understand, that it's too complex, it's too complicated, then there's no point in trying. Yeah. We know that people can, and we have to meet them there. And that's exactly what we're doing at the Pandemic Prevention Institute.
Bertha?
Yes, I fully agree, and also very grateful to have been included in this. I also learned a lot from everyone in today's conversation. I am a big believer that we need to bring science to the people. And that starts, I think, very early on in the education spectrum. We know that there are disparities with respect to the quality of education that is offered all across the US and other countries. And so that if we have systems in place where we have effective science communicators that can take that, role and bring science communication to schools, to digital platforms that we know are being accessed readily by populations that may not necessarily be well aware of the technical terminology of the topics that we're talking about, that I think those are the ways in which we're going to increase knowledge, we're going to increase empowerment, and really decrease and eventually eliminate optimism again, those disparities that are so disproportionately affecting so many people.
G2, any last thoughts?
The way what really surprises me is that given what we have already experienced in the pandemic and the power of as Bert had mentioned, just within months of the pandemic sort of striking, there have been solutions, I think if we cannot talk about that in a manner that is, both laudatory as well as measured in terms of what its limitations are and what potential it brings, then I think as scientists, we have failed in making the case for science. and
Yeah.
and I think in science communication, again, as Sam was saying, is perhaps the most important way of creating and building trust. Not propaganda, but communication. And I think that's something that one needs to learn how to actually deliver. I mean, when we as scientists often talk about what we do and what we can do, it very often sounds like full of propaganda, that the public should support us because we do good science, and good science is good for you. And I think that kind of sort of trivializing doesn't help anyone. And I think the way forward, I feel, is really beginning to bring science and scientific thinking and scientific temperament into people's lives and where it matters. And that's the only way I think we'll be able to create this sense of trust. So,
Yeah.
I must say, the efforts that you're making in doing this, having such a program, is part of that. And I think that's fabulous, and I'm grateful to be part of it. Thank you.
Yeah. Well, I just want to thank you all for spending the last hour and 2 minutes with me. Apologies for going a little bit over. This was such a fruitful conversation, and I want to let all of our listeners know that this has been recorded, that we'll have access to watch it again if you would like to share with others, and we'll be doing conversations like this more in the future. To end on this optimism, I think, is the right thing, because we know that we are just collecting more and more tools to solve these problems of pandemics, and hopefully can get to the place in which we can prevent further pandemics, prevent next waves. So stay tuned and follow Rockefeller Foundation and the Pandemic Prevention Institute for more updates. Thank you all again for participating and for your time. Thank you all for watching. Take care and be safe.
Thank you, Jessica. Thanks, everyone.